Buenas noches a todos. Es un gran placer estarmos dando inicio a este webinar de SOLACI, que tem trazendo as grandes novidades do mundo científico que impactam a cardiologia intervencionista. Eu sou Ricardo Costa, intervencionista do Instituto Dante Pazanese em Brasil, São Paulo, Brasil, e atual presidente da Sociedade Sul-Americana, Latino-Americana de Cardiologia Intervencionista, SOLACI. E estaremos participando conjuntamente com destacados intervencionistas de nossa região, Dr. Mário Araya, ex-presidente de SOLACI, que atua em Chile, e também Dr. Alejandro Ricalde, de México, que é nosso secretário da atual gestão. E de forma muito destacada, teremos também um convidado internacional, que é o Dr. Simon Eccleshall, que desde já agradecemos muito por estar conosco. Já está em Reino Unido, mas está cá. É investigador principal dos principais estudos que foi discutido no último congresso TCT em Washington, com grande repercussão, e que é o nosso objetivo neste webinar de estarmos discutindo. Então, sem mais delongas, nós outros iniciaremos agora a primeira charla. Já teremos um número grande de participantes acá com nós de todo o continente, e estimulamos desde o primeiro momento que as perguntas, os comentários sejam enviados pelo chat, para que possamos ter uma discussão muito rica dentro desta hora que estaremos juntos acá. Neste momento, então, estarei compartilhando Ok. Podem ver acá? Posso começar, Juan?
Sim.
Ok. Então, estaremos iniciando falando um pouquinho sobre a tecnologia SELUTION, com suas características e a experiência clínica inicial. Então, o que temos acá, o primeiro racional por que os balões farmacológicos ou drug coating balloons, todos sabemos que os stents, apesar de serem muito eficazes, stents farmacológicos, há problemas que podem acontecer, principalmente no longo termo, com a inflamação persistente relacionada a eventos isquêmicos, na faixa de 2 a 4% por ano em todas as séries, continua acontecendo. Então, evitar a presença de um stent, evitar a toxicidade que pode acontecer em largo prazo poderia ser vantajoso, e também naquelas situações onde a presença de um stent ou a estratégia de tratamento com stent pode não ser o mais ideal, seja do ponto de vista anatômico ou mesmo clínico. Acá temos uma série de estudos comparativos que com balão farmacológico e stent farmacológico que sugerem que a partir do primeiro ano a taxa de eventos com balão farmacológico torna-se praticamente uma linha flat, enquanto vemos um incremento com os stents farmacológicos ao longo do tempo. Há algumas diferenças muito importantes em pensar na estratégia do ponto de vista técnico. Com o balão farmacológico é muito importante, crítico, a preparação da lesão, a seleção e preparação, e também o manejo de dissecções, pero há vantagens também em relação a utilização do dispositivo de forma mais forgiving, enquanto que no stent é muito importante a precisão do diâmetro, da extensão, do posicionamento e, claro, da otimização. E há alguns cenários como a rama e mesmo a guida da imagem que o DCB pode ser menos dependente disso para um resultado
menos dependente desse tipo
de componentes dessa tecnologia. Obviamente, há muita importância para o tipo da droga, a sua dose. Quanto mais eficiente a transferência, menor a dose, a formulação e como isso deverá ser carreado, o polímero que pode ser usado para esta necessidade, e também o tipo da cobertura que é utilizada. Cada uma tecnologia tem suas próprias características, então é correto considerarmos que, mesmo que a estratégia seja similar, os diferentes tipos de balão farmacológico têm diferentes características e, também, dessa forma, podem ter também um impacto clínico diferente. Quando comparamos os dois fármacos que são utilizados, paclitaxel e sirolimus, muito conhecidos de nós outros, pois já são aplicados em estente farmacológico, veremos que
we will see
a
that
droga sirolimus pode apresentar alguns desafios para ser utilizado dessa forma, por ser menos lipofílica.
this is less lipophilic and more complexity for coverage or coating. There's still
lenta e também a retenção pode ser menor, por isso a importância de ter um sistema carreador muito delicado. Quanto ao paclitaxel, é mais lipofílico, mas tem também uma absorção mais rápida. Acá introduzo então o dispositivo SELUTION, que tem duas características muito destacadas que nós podemos comentar, que é uma combinação com micro-reservoir que levam conjuntamente o fármaco sirolimus com esferas de 4 micras, que permitem que o fármaco seja devidamente carreado até o sítio da lesão, do tratamento, e haja uma liberação também mais lenta, mimetizando aquilo que se espera que aconteça de um stent farmacológico e que sabemos que está relacionado também à eficácia local que atingimos com esse dispositivo. Com relação a esta tecnologia de liberação, vemos acá um pouco mais de detalhamento, que também essa tecnologia é capaz de deixar uma transferência muito homogênea em todo o sítio de tratamento, uma vez que o balão é insuflado dentro da coronária. E talvez muito importante esta ilustração que mostra a farmacocinética de sirolimus deste dispositivo, que mostra que é detectado a presença tecidual até 90 dias, ou seja, assemelha-se muito a uma liberação mais prolongada e controlada, conforme nós vemos em los stents farmacológicos. Trago agora os resultados do primeiro estudo em humanos que nós participamos, que foi o estudo First in Man com essa tecnologia, realizado em 56 pacientes em Ásia, e que havia os endpoints de segurança inicial e também os endpoints de eficácia ao final dos 6 meses, em um ano. E aquela população com nível muito elevado de diabéticos, 46%, a extensão da lesão 10,6 milímetros, vaso de 2,35 milímetros, e acá o resultado principal, um leito lumelose de 0,26 ao final de 6 meses, todos os casos sendo tratados com muito sucesso. Acá a distribuição, vejo que a leitulose é uma distribuição mais estreita, mais narrow, mas o que mostra a uniformidade da resposta desse tratamento. E não tivemos eventos até 12 meses, como morte e infarto, somente uma nova revascularização aos 6 meses. E acá alguns exemplos, temos um pequeno grupo de pacientes que eram restenose intrastent, vejo restenose intrastent muito complexa, a descendente anterior proximal, e tratada com o balão SELUTION, depois de 6 meses, um resultado muito sustentável. Acá temos o grupo maior desse estudo, foi as lesões de novo, e acá algumas características do QCA desse subgrupo de pacientes. Acá os resultados agudos e os resultados com 6 meses, um leitulose de 0,16 milímetros da lesão de novo. Acá um exemplo, uma circunflexa distal com uma lesão muito grave e pós-procedimento e ao final de 6 meses um resultado absolutamente sustentável, muito eficaz. Um outro resultado, uma rama lateral, tratando de uma maneira simplificada o tratamento, somente com stent, vaso principal e a rama, com balão farmacológico, e vejam que o resultado de 6 meses também muy sustentable. Y acá los resultados, la distribución de los resultados muestran también lo percentual de hemostenosis, una diferença muito pouco expressiva entre o pós-procedimento e ao final de 6 meses, e leito luminoso também, distribuição muito estreita, narrow, 0,16 na média e 0,12 milímetros na mediana. E o último, teremos então um programa muito extenso com esse dispositivo, mais de 5.000 pacientes, em diferentes estudos, diferentes cenários, e o grande destaque acá é, sem dúvida nenhuma, é o estudo SELUTION DENovo, com mais de 3.300 pacientes realizado em múltiplos centros, Europa e Ásia, e temos como investigador principal o Dr. Simon Eccleshall, juntamente com o Dr. Chris Paulding, e é um grande prazer para nós, em nome de SOLACI, nossa comunidade, mais uma vez dar as boas-vindas para o Dr. Eccleshall, que agora, na sequência, nos falará sobre os resultados desse importante estudo recentemente apresentado. Então, Dr. Simon, por favor. Simon, thank you so much once more. A real privilege to have you here. And I'm going to hand now the word for you to present the results of the SELUTION DENovo. And after that, we're going to have some time for discussion. Thank you very much.
Great. Thank you very much. It's an absolute pleasure to join you from Norwich in the UK, where I work as an interventional cardiologist. It's in the UK terms, a medium-sized heart attack centre. So we do about 15 to 1,800 PCIs per year. We're a non-surgical centre, so essentially we have to deal with everything that comes in the door. And we've now been working with drug-coated balloons for about the last 15 years. And what I'm going to present to you this evening is the one-year results that were presented at TCT for the SELUTION DENovo RCT. When this starts working. There we go, that's my disclaimer. So the one-year results of SELUTION DENovo, as presented at TCT, the original presentation and the slides were by Christian, my co-global PI. I've used his slides and modified them slightly because obviously things have changed in the last few weeks from the point of view of emphasis. So I'll now take you through the results of the one-year outcomes. So we all know, and you've just heard again, that although stents are widely used in PCI, there are some problems with them, and these problems seem to be late with an attrition rate of 2% or more per year, depending, not related to what type of stent you use. As you can see here with a landmark analysis on the right, both bare metal first generation and second generation drug-eluting stents seem to have this event rate out to 4 years post landmark analysis. And in fact, this has now been shown up to 10 years down the line as well. So there's obviously an attrition rate there. And if we could avoid that in some way, that would be in the patient's benefit. This was first done with paclitaxel balloons. And what we're trying to do now is build on that, perhaps with more targeted therapy aimed at the restenotic cascade and possibly the inflammatory and thrombotic events that occur at the same time. So this was the rationale for the SELUTION DENovo study. It's prospective, randomized, open-label, multi-center, non-inferiority trial. Essentially, anybody who could go into the trial had an angiogram done, and then based on that angiogram, the operator had to commit to either they could treat everything with a stent or everything with a SELUTION DEB. In the DEB arm, you were allowed to put in stents for all the usual reasons of a vessel-threatening dissection or a suboptimal lesion preparation result. And we were hoping that this would happen in less than 30% of the cases. So they were randomized before angioplasty, and then they stayed in the balloon arm or the stent arm as a strategy. And the first co-primary endpoint, which was non-inferiority for target vessel failure at 1 year, is what we presented just at TCT. Target vessel failure was defined as a composite of cardiac death, target vessel-related MI, and clinically driven target vessel revascularization. So the difference between this trial and all the other preceding DCB trials is this is a strategy trial. So we're very much aiming at the concept of trying to treat everything with a balloon, bearing in mind you are allowed to use stents if you run into problems, against treating everything with stents. So the key inclusion-exclusion criteria are listed here. Essentially, to be included, all your lesions had to either be treatable in your own eyes, the operator in the lab at the time, with a balloon or with a stent. The vessel diameters were between 2 and 5. There was no limitation on the number of lesions or vessels, except we didn't want people putting in patients who they honestly thought they were going to be bailing out in more than 30% of cases because of the complexity, or probably more because of the number of vessels and lesions that they were treating. The exclusion criteria are listed there. The most important ones: STEMI and unstable non-STEMIs, left main, any graft, any CTO, and any in-stent restenosis. And obviously all of these will be addressed in particular trials. We also specifically excluded PCI in a target vessel, a previous PCI in a target vessel, because we were trying to avoid those late stent complications that we mentioned earlier. So we didn't want that confounding our results. Procedural guidelines for operating during this study. In the stent strategy, it was systematic drug-eluting stents as per the guidelines and local practice of that centre. So current generation approved devices and optimised in whatever way you saw fit. And your lesion preparation was how you would normally go about your stent strategy. In the solution arm, it was mandatory to undergo optimal lesion preparation as per the most recent consensus document that we'd written on the subject. But we were aiming for 1-to-1 balloon to artery ratio as judged by an angiogram with our lesion preparation balloons, and then with the solution balloon itself. And that should have been inflated for a minimum of 30 seconds. And then stenting could be used if there was a residual stenosis or recoil of over 30%, if there was a vessel-threatening dissection, or if you were assessing physiology at the time and it was still shown to be ischemic. The antithrombotic treatment that patients required was as per local guidelines. Stage procedures were allowed, but had to be done within 45 days of the index study procedure. Use of adjunctive devices was all at the operator's preference, which included any cutting, scoring, or high pressure balloons, any calcium modification, any form of intravascular imaging, and any form of physiology. So this is the study organisation. It's the first time I've been involved in anything this big, and I have to say that the whole thing was, for me, a great learning experience, and just shows how fantastic these sorts of people are, how good they are at their jobs, and what a big job actually it is to do. Speaking of which, we have to thank all the countries, 12 of them, and the centres, 62 of them, and we've named there all the centre PIs and the country PIs, and between all of them they did a fantastic job of getting this study over the line in a very timely fashion. So the sample size and statistical analysis, as I said, the endpoint at 1 year is target vessel failure, which is a composite of cardiac death, target vessel MI, and clinically driven target vessel revascularization. We assumed an event rate of 6%, and we could talk about this again a little bit later, but you have to start somewhere. And what we could work out from drug-eluting stent trials of a similar all-comers population was that this would be an expected event rate at 1 year. It was more difficult because of the relative paucity of similar drug-coated balloon trials that were out there. The non-inferiority margin, because the event rates were around 6% or possibly less, and we wanted to guard against even lower event rates, as, for example, have been seen in other trials such as RET cage free. We took it as 50% of the overall actual target vessel failure rate in both arms. With a one-sided type 1 error, as you can see there, power of 95%, we expected 2% loss to follow-up with a sample size there of over 3,300. On the right is the example, if we had had an event rate of 6%, showing that you had to be within that non-inferiority confidence interval as shown. But obviously, as you will see, the event rates change. So this is the consort diagram. We randomized 3,341. A few were excluded along the way because they did not undergo an angioplasty. which then means that we are essentially not quite assessing an intention to treat, but it's what you'd call a full analysis set, which is a full analysis of all those that actually underwent an angioplasty rather than per protocol. And at 12 months follow-up, you can see the numbers with 98% compliance, which is a fabulous job to have been done by our research team. So the clinical baseline characteristics, you can see they're very, very standard for a European randomized controlled trial in the angioplasty field. High bleeding risk was represented by just under a fifth in both arms, and acute coronary syndrome in over 30%, again in both arms. Angiographic characteristics, I'm delighted to say that nearly 20% of patients had a proximal LAD lesion, which has always been one of the hurdles that I think a lot of interventionists have come up against, is the idea of not stenting the proximal LAD when they're performing an angioplasty. The device size, which is how we defined the vessel size for the analysis so far, was over 2/3 in both arms was 3 millimeters or more. Again, essentially saying that this is a big vessel study, which is what we've all been waiting for, really. Moderate to severe calcification was in just under a quarter of patients in both arms, and type B2 or C lesions in 2/3. So there's a more complex patient group here than was seen, for example, in RET cage 3. Procedural characteristics is a European trial, so it was all done radially. Specialty balloons were used more frequently in the balloon arm than the stent arm, and this probably represents current European practice. Atherectomy and IVL was only used in a small percent of cases. Intracoronary imaging around 15 to 18%, and anybody in the UK will tell you it was driven pretty much exclusively by the UK. The bailout rate in the balloon arm per patient, which is probably the most useful number, I think, runs at 20%, i.e. 80% of all of the patients in the balloon arm finish their procedures either one or staged without any stenting at all. Procedure duration was relatively long, at over 50 minutes in both arms, again suggesting that we were doing fairly complex angioplasty with a number of lesions per procedure. These are the primary endpoints that were presented at TCT. Target vessel failure at 1 year. The drug-eluting stent arm was 4.4%. The SELUTION DEB arm was 5.3%. As you can see, this changed the non-inferiority margin because you have to take the 2 event rates that you see there to work out what we should be aiming for. But we met non-inferiority with a p-value of 0.02. The components of the primary endpoint are shown here, which are cardiac death, target vessel MI, and clinically driven TVR. And I think some people are already getting a little bit worried about the difference in clinically driven TVR. This was the big driver in RET cage 3. And here you can see that there is a little bit of a difference. It's just over 1% more clinically driven TVR in the balloon arm. But we already know a number of things about balloon against stent studies, in that there is always a bias to more patients ending up in the lab for repeat procedures in the balloon arm. And also when you're in the lab, there's again a bias to you're more likely to undergo a PCI if you've only had a balloon treatment in the past rather than a stent treatment. And to that end, I'm beginning to think that unlike cardiac death and target vessel MI, that target vessel revascularization is more of a choice than it is a hard clinical endpoint. Speaking of which, if you're worried about more TVR in the balloon arm, perhaps you should be worrying a little bit more about the very hard endpoint of cardiac death being worse in the stent arm. We could probably talk about that again later. One of the things that people always worry about in balloon trials is the idea that lots of patients are going to go back to the lab within the first 24 hours with acute vessel closure. And we've shown quite convincingly here that periprocedural MI, acute and subacute lesion thrombosis and late lesion thrombosis were similar between the 2 arms and very reassuringly low. And this backs up a lot of previous data from drug-coated balloon trials and some of the retrospective work that we published from our own centre showing very low acute vessel closure rates. Subgroup analysis, here's the standard forest plot. It always looks quite busy. I'll draw your attention to these interactions. There seems to be an interaction with sex, there seems to be an interaction with high bleeding risk, and again with moderate to severe calcification. We can't really say any more about that at the moment until we've looked at all of this in a lot more detail. So the limitations of this trial, although it had broad inclusion criteria, we did exclude STEMI, CTO, ISR, left main and grafts, and a lot of these I'm sure will be addressed in dedicated trials in due course. Lesion preparation reflected current European practice with probably limited use of specialty balloons and calcium modification. Certainly in our centre, in my hands, I would be using cutting and scoring balloons in over 50% of all the angioplasty that I now do. We don't yet have QCA analysis available. And lastly, the study was performed with a very particular solution drug-eluting balloon. The results, as is always said at these sorts of meetings, cannot be applied to any other drug-eluting balloon or drug-coated balloon. There is absolutely no class effect. So in summary, this is a large pragmatic study that randomized patients before lesion preparation. So it's different to every other DCB trial before it, which was device randomization. There are no acute or late safety concerns. 80% of all the patients in the balloon arm did not receive any stents. These results with these broad inclusion criteria, I feel, can apply to the vast majority of all the PCR that we do on a daily basis. And 5-year follow-up will hopefully again show non-inferiority, and we're then powered to look for superiority of a strategy of DEB with solution with minimal stenting. So my first conclusion slide is at 1 year, solution DEB with provisional stenting was non-inferior to systematic use of drug-eluting stents, or in my own opinion, to put it another way, this is a game changer. My second conclusion slide is, I think PCI is changing. Optimal lesion preparation is now what we should be working for in all of our cases. And then you can choose your destination therapy, which could be a drug-eluting balloon, it could be a drug-eluting stent, it could be a scaffold. Thank you very much.
Thank you, Simon. This was just excellent. And we feel privileged to have here the PI because I see a lot of questions already here in the Q&A. Really the sense that for those of us who were in that arena, listen to the results, was that we are facing maybe a changing paradigm in terms of what we could do in interventional cardiology with this new technology and how does that could change the field. And of course, significantly impact what we do in the daily practice. I have also my own questions, but I will like to ask Mario Araya, our panelist. Mario, sus comentarios y también preguntas para el Dr. Simon. Lembrando que tenemos la tradução simultânea, Dr. Simon também recebe a tradução simultânea em inglês, então cada pode falar como quieres. Mario, por favor.
Perfecto, Ricardo. Muchas gracias. Gracias por la oportunidad a todos de Accordis y a ti, Ricardo, de poder estar acá en la discusión de este muy importante trial. Yo creo que, como bien dijo Simon, estábamos todos expectantes por este trial que afortunadamente nos dio información muy valiosa y que puede ser un game changer, sin duda. Ahora, como cualquier trial que nos impacta de esta forma, hay cosas que tenemos que entender, cosas que tenemos que analizar. Lo primero, quizá un comentario, es que para mí el principal mensaje de este trial es que el uso de SELUTION DeNovo lesions, en lesiones de novo, con un alto porcentaje de lesiones de más de 3 milímetros, es muy seguro. Es igual de seguro que instalar un stent. Me parece que esa es como una premisa que tenemos que utilizar, pero considerando una óptima preparación del vaso. Y aquí viene tal vez mi primer concern o pregunta a Simon, no sé si él me logra entender. Felicitaciones, Simon, por el trabajo, por Me imagino yo que fue muy ardua la tarea para juntar este seguimiento a un año, y va a ser aún más ardua juntar el seguimiento a 5 años, ¿no? ¿Hubo alguna diferencia fundamental entre la preparación del vaso en el grupo DCB versus la preparación del vaso en el grupo stent? En la práctica diaria, lo que yo veo es que cuando uno utiliza un balón farmacológico, uno prepara la lesión con más ahínco, con más tiempo, más dedicación. De hecho, en nuestros datos, los procedimientos con DCB son más largos, con stent son un poco más cortos. ¿En este trial hubo alguna diferencia en la preparación del vaso entre los dos grupos?
Thank you. So, yes, it was a lot of work. Most of it wasn't done by me. I was very fortunate to be involved in it, and it's been a fantastic learning experience. So thank you for those kind words. Did we see a difference in lesion preparation? So I think you can see it in the fact that there were more specialty balloons, such as cutting and scoring, used in the DEB arm than in the stent arm. However, the procedural duration was virtually identical between the two arms. We haven't looked in detail at what sort of lesion preparation people did in the stent arm, because we just let them do what they normally do. But I suspect that, yes, there will be a difference. And I think I sort of alluded to this in my last slide, in that I think with time, one of the hidden benefits of talking about drug-coated and drug-eluting balloons is people are beginning to realize that the important bit of the angioplasty is actually the bit that's done before that. So it's all about the lesion preparation. So I think eventually we'll end up in a world where optimal lesion preparation will be done all the time, and then people will choose between which device they need to put in. And that may well mean that when people are putting in stents, the event rates are low because they've done such a good job of their lesion preparation anyway. But we haven't specifically looked at the difference between lesion preparation between the two groups. We've just let operators do what they normally do in the stent arm.
Simon, one question, and then I want to hand it to Alejandro Ricalde after. Las 20% de los pacientes necesitaron un stent. Quem são esses pacientes? É possível saber, há tipo de lesão, tipo de localização, vaso, uma condição que é mais propensa a receber stent? E há uma diferença também entre centros ao longo do estudo ou com mais ou menos volumes que podem ter alguma diferença nesse sentido? E qual a sua interpretação? E por último, que tem a ver com isto também, se você entende que esta tecnologia ela vem para substituir o stent ou para ser uma atuação de forma combinada com os stents?
Thank you. That's about 10 questions in one go. That's cheating. Right, I'll deal with the last one first.
Straightforward.
Which is, I think drug-eluting balloons will be complementary with drug-eluting stents and scaffolds. And I think the important thing from my point of view is, I think currently the balance is wrong in that lots of people have a lot of stents put in when they didn't need that much metal work for the rest of their life. And I think just resetting the balance is an important place to start. And I think, as I said on that last slide, we will end up using all three of those as destination therapies. I think within the next few years, we could get to a point where the majority, maybe 60%, would be drug-eluting balloons. Second, probably when the scaffolds have gone through a little bit more research and development, would be scaffold in maybe 20-30%. And I think drug-eluting stents will become the niche product out of the three of them. But we will never get rid of them. I just think that we'll change the emphasis completely. Right, the rest of what you asked about was all about bailout. So when we were still recruiting, one of the things we were quite interested in, because we were feeding back to centres as to how they were doing their drug-eluting balloon angioplasty in the trial and when they were bailing out. We've looked at every single bailout case throughout the whole study. And we fed back to those centres that were relatively new to DCB and DEB work, explaining what we thought perhaps could have been done differently. And one of the things that we found early on, after about 1,000 DEB cases, was the early cases from centres as compared to later cases from the same centre, that the bailout rate went down across the board for all the centres as they got more experience, and the complexity of the angioplasty went up, which I thought was fascinating. Overall, as we said, it was 20% of patients ended up with a stent, leaving the lab within the balloon arm, which some people think is a bit disappointing. I think it's a complete shift, paradigm shift in how we do our angioplasty, as in the vast majority of patients no longer need an implant to be safe. And have we picked up yet what sorts of cases those were angiographically? Well, QCA isn't yet available to us for all of these. From previous experience, some of the things that you tend to pick up particularly would be tortuosity and very diffuse disease are predictors of more chance of having a vessel-threatening dissection and therefore needing to be stented. But it's a very good point and something that we should consider when we look at, because we're going to be looking at how many patients had stents, why they had them, and very particularly about the learning curve, because some of the other things that we've already noticed about the learning curve, which we sort of loosely associating with the bailout rate per operator or per centre, across the board, it was 20%. For the high volume centres, as in those with over 100 cases into the trial, it was half that number, it was 10%. And in those centres that were high volume, that also had a lot of previous DEB experience that we knew of, it was nearer 5%. So I think that that's a fascinating bit of work that we need to look at in a lot more detail, because there's so much data in this large trial that we need to understand and then share. I think that answers all your questions. You might just need a couple more.
Absolutely. Alejandro, your comments and questions, please.
Gracias, gracias Ricardo. Saludos Mario, saludos Simon. Tengo dos preguntas particulares. La primera es, la apuesta, digamos, el beneficio claramente de la data que teníamos previo a este estudio se ve a largo plazo, con estas curvas que se aplanan para los balones liberadores de fármaco, y la apuesta entonces será una superioridad a 5 años. Primero, la primera pregunta es, ¿cómo logramos definir sobre todo no el vessel revascularization, no el TLR o el TBR? Porque para balón medicado es muy difícil saber cuál es el sitio específico de la lesión donde se trató cuando le damos seguimiento a largo plazo. Entonces, mi pregunta será, si ustedes van a ver el target vessel restenosis o el target lesion restenosis. Esa es la primera pregunta, porque creo que ahí puede haber un sesgo si no hay un core lab independiente que vea el primer estudio. Y la segunda, y creo que esta, espero no hacer un gol, que así le decimos en México, es creemos que podemos expandir estos resultados a cualquier tipo de liberación de droga, es decir, a cualquier tecnología, o esta es específica de Selution por los reservorios, por el grado de depósito, por el tema de que es SIROLIMUS. ¿Tú crees que esto se puede expandir a cualquier balón? Es decir, ¿cualquier balón va a ser igual o esto es algo muy específico de Selution y no lo podemos trasladar a los demás balones liberadores de fármaco?
Okay, thank you. So, second question first again. So, the endpoint of target vessel failure, it obviously is a composite of all the early safety events as well as or the later events. Now, early events are more related to how good you are at doing your angioplasty, as in you don't get horrible complications and early acute vessel closure because you did a very bad stent case or you did a very bad balloon case. So from that point of view, one of the things that you can take away from this trial is if you do good balloon angioplasty and you follow all the usual consensus documents as to how to do that and how to assess the safety, that's something that can be transferred into any trial, and that is transferable from the other trials that are already out there, such as Basket Small 2. Where it becomes device specific, presuming that they're all safe balloons, and you will know that from the first-in-man trials, where it becomes very device specific, therefore, is the 1 and the 5 year outcomes, because these are mainly driven by target vessel revascularization, which absolutely comes down to two aspects. One, again, have you done a good enough angioplasty? But secondly, and most importantly, have you used a balloon that delivers the drug in the right way that gives you the result that you're really looking for? So hopefully that's answered your second question. Remind me very briefly what your first one was. Oh, I know, TVR and TLR late. Okay, yeah, so it's all core lab. So every patient has all of their initial work sent for QCA, and any patient that goes back to the lab, all of those angiograms will be submitted to the same independent core lab, and they are absolutely fastidious about ensuring that they are talking about the right segment of the right vessel all the time. So yeah, we trust the core lab from the point of view of what they're doing with the QCA analysis. So hopefully it will tell you exactly what you were asking. Is it just a TVR or is it a TLR or is it both?
Simon,
Yes.
antes de pasarmos para los casos que el Dr. Ricalde nos apresentará,
Great.
Temos acá 11 perguntas. Vamos tentar fazer rapidamente. Dr. Jorge Eduardo Chavariga Quicheno, se la utilización del tratamiento medicamentoso optimizado con las estatinas, con los inhibitores SGLT2, después de la implante de un balón liberador de fármaco, podría mejorar los resultados?
Well, I think all of the drugs that are currently now being used that weren't being used a while ago are driving event rates down anyway, aren't they? Very specifically, I don't know, we need to do the trials to see whether there is any direct impact, I presume they mean on restenosis later. But I think all the much more aggressive secondary prevention that we use means that event rates are lower across the board, and this is being seen in all PCI trials. I think that's as much as I can answer on that.
Yeah, it's definitely a good rationale. Second question, I think we already comment about how do you see the condition that solution has a prolonged pharmacokinetics for sirolimus up to 90 days. How much you think that speaks for its efficacy?
I think it speaks hugely for its efficacy. It's been shown to have the drug in the right place for long enough, as is shown with drug-eluting stents, and that's exactly what you want it to do. And I think it's taken people about a decade to work out how to do it effectively with sirolimus in the way that it was relatively easy with paclitaxel at the beginning. And we mustn't forget that we're only all here because paclitaxel balloons did actually work. And what we're trying to do now is refine that process and possibly improve on it with the different drug.
Okay, question from our colleague Pedro Hidalgo, Vice President of SOLACI from Venezuela. Thanks for being here, Pedro. What scenario, what specific anatomical and clinical scenario you never consider to use a DCB alone treatment? I have an answer for my own answer, but I want to hear your answer.
My answer is I start off every angioplasty expecting to finish with a balloon only, but accept that I have a stent on the shelf if I really need it. So there's a number of us that are already published, for example, on primary angioplasty, as in STEMI with DCB, and also left main stem only de novo DCB work. So I don't think there's any barrier. I think it's just a question of learning all the different ways of doing your lesion preparation and the safety of your angioplasty.
Okay.
How about you?
I think left main alone we should leave behind. But
let's do the trial.
Yes. Mario, you want to comment?
Yes, sí, Alejandro, yo creo que tu pregunta sobre los otros balones es bien interesante. Lo que yo pienso que va a pasar después de este estudio tan bien hecho y con este resultado tan prometedor es que las casas fabricantes de balones con sirolimus o paclitaxel van a tener que hacer en algún momento un face-to-face, ¿no? Yo creo que será difícil que otra casa haga un estudio de esta magnitud. Simon, una pequeña pregunta del trial, del diseño. ¿Cuál es la ventaja de este trial estratégico, ¿cierto? Que usted bien lo dijo, de randomizar antes de la preparación de la lesión? ¿Por qué no se randomizó posterior a la preparación de la lesión?
Thank you. We wanted it to be more real world. So in the real world, people don't do lesion preparation until they've got a really, really good result and then decide, are they going to put a balloon or a stent in? If you were in that scenario and you did really good lesion preparation and were then trying to decide, all the previous device trials would tell you the answer, which is that either of them is reasonable. What we were trying to do is shift the emphasis a little bit and say, it's not just, is it one device or another? It's, what is your strategy? Is your strategy stent everything, or is your strategy treat the restenosis in a different way and only stent that small percentage of cases where a stent is your only option? And that then means that you will shift the conversation on to, it's all about good lesion preparation, but also it's all about the phrase that I quite like is minimal footprint angioplasty, which is leaving as little behind as possible, whether it's just a drug or a bit of scaffold that disappears quite quickly, or if you really have to, then as little metal as possible.
So, Simon, there's one provocative question here.
Just one.
If DCB it's equivalent to DES, why so much focus on lesion preparation, optimal lesion preparation?
Because all the drug is ever doing is giving you the anti-restenotic effect later. So you have to have the good safe lumen gain at the beginning. So all the QCA, any angiographic trial that's out there, and you know this because you've done them, will show that at the end of your procedure, in the balloon arm, it doesn't matter how hard you work, you will not get the same acute lumen gain that you get with a stent. But what's quite beautifully been shown with some follow-up work, both with angiography and physiology and imaging, is over time, that stent is only ever going to look worse, whereas quite often over time, your balloon looks better. So you have to do the best lesion preparation that you can to render the patient safely non-ischemic, and then you're relying on the drug. Whereas in the stent arm, it's all about how much lumen can you get acutely, because it will never be that good ever again.
And you mentioned before, if we did a better job lesion preparation for stents as well, we're probably going to get less adverse events. So I think that speaks for whatever we do. Last question before we move to the cases. Two questions I'm going to put in one. One question, your comment related to the impact and efficacy, not in the study itself, because I understand you're still going to have some analysis to be done for this answer, but your word about DCB in large vessels. And then that's a question for José Armando Mangione, our colleague from Brazil. former president for SOLACI. Based on the results of SELUTION DENOVO, would you feel comfortable or expanding this for more complex lesions like type B2 or C? And then I would say the real complex ones, the left mains, the CTOs, the complex bifurcations, all the ones that were excluded in the trial as well?
So there's already has been lots of work with drug-coated balloons in all of those scenarios. Most of them aren't yet RCTs. There's lots of retrospective propensity match type work that's been done. I think one of the messages that seems to be coming out of the whole drug-coated balloon philosophy is the more complex the patient and the more complex the lesion, the easier and the safer it is to do it with either fewer stents or no stents, as long as you get a good angiographic result. So in our hands, for example, in our centre, we're now beginning to see that cost analysis-wise, there's no difference between using balloons or stents, bearing in mind that in the UK, a drug-eluting balloon is at least twice the price of a stent. But everything else around it makes it cheaper because we don't need to do as much imaging. We're certainly not imaging after a DEB, for example. But the other thing that seems to start showing up is, surprisingly, we're using less contrast and we have shorter procedure times in the DCB group than we do in the stent group. And I think that's because we're taking things that look quite complex and actually making them simpler, which is much safer for the patient. And actually, the sicker the patient becomes, the less you ever want to do, as you well know. You just really want to restore flow to buy some time rather than worry about optimizing that stent, for example. I'm not sure I answered the question.
Oh, absolutely.
Is that it? Okay.
Absolutely. So we're going to move now. Estaremos agora avançando com o Dr. Alejandro Ricalde, que nos apresentará alguns casos de la prática diária, de certa forma, exemplificando o que estamos discutindo acá, como isso se aplica à la prática, e depois poderemos finalizar aquela discussão. Realmente, as perguntas não param, é uma participação, muito interesse desse tema, e destacaria também que teremos 150 pessoas conectadas acá de todo o continente, o que é fantástico, realmente uma discussão muito válida para todos nós. Alejandro, por favor.
Muchas gracias, Ricardo, muchas gracias por la invitación y por darme este espacio para compartir algo de lo que hacemos en el día a día en México, y hablando de balón liberador de fármaco, en específico de Solution, en estos casos en de novo lesions, que es donde hay un poquito de experiencia más inicial, digamos, con respecto a la restenosis intrastent. Entonces, vamos a empezar por un caso y creo que se aterriza bien a lo largo de estos dos casos que les voy a presentar, como no quisiéramos dejar una gran cantidad de metal en este tipo de pacientes, ¿no? El primero es un paciente de 63 años que vino con un infarto agudo del territorio del ascendente anterior y se le puso un stent. Y entonces nosotros, ahora un colega mío lo hizo durante el agudo y después venimos a terminar el procedimiento. Estas son las imágenes del infarto agudo. En el infarto agudo se trató la arteria descendente anterior, pero ya podemos ver claramente aquí la enfermedad difusa que tiene a nivel de la arteria circunfleja, de los ramos del margen obtuso, y esta descendente anterior claramente ocluida con el infarto agudo, y una coronaria derecha que tiene una lesión digamos, intermedia en el segmento proximal de la coronaria derecha, y que tiene esta lesión que no me parece tan significativa desde el punto de vista angiográfico. Pero bueno, es un paciente que así terminó el infarto agudo. Déjenme bajar el volumen de esto. Es un paciente que termina con con un stent en la descendente anterior. Por ahí queda la duda, a lo mejor en este segmento, cómo quedó el stent, pero el paciente regresa 5 días después para completar el tratamiento en esto que es la estrategia de revascularización completa por etapas, como como las guías nos lo marcan, ¿no? Entonces tenemos esta lesión, y acá les enseño la lesión de la circunfleja, de los ramos del margen obtuso y la coronaria derecha a los días que la metimos a los 5 días. A revisar, lo que hicimos fue preparar inicialmente la lesión de la arteria circunfleja y aquí decíamos de que tanto importa, es muy importante tener claro esto nada más como recordatorio, que una buena preparación, y esto en función, lo acabo de meter en función de la pregunta que hicieron, una buena preparación de la lesión en términos de balón liberador de fármaco sí hace la diferencia. ¿Y cómo decimos que está bien preparada la lesión y que podemos terminar con un balón liberador de fármaco? Estos son los criterios más aceptados, que tengamos un flujo TIMI-3, una estenosis residual de menos del 30% y que no tengamos una disección mayor o una disección limitante de flujo. Y después hacer una buena liberación del fármaco implica llevar el balón, es decir, haber hecho una buena preparación, después hacer una angioplastía con o en una entrega de la liberación del fármaco con un radio de 1 a 1 con respecto a la arteria. Hay que recordar que no se usa el balón liberador de fármaco para hacer angioplastía, para abrir el brazo, simplemente para entregar la droga. La preparación se hace previamente. Y aquí, a diferencia de los stents, podemos extendernos un poco más, se sugiere extendernos un poco más, 2 milímetros proximales y distales a lo que es la placa y hacer una liberación de al menos 60 segundos para que se haga una buena liberación del fármaco, lo cual también va a impactar tanto la correcta decisión del tamaño como el tiempo de liberación, impacta en el pronóstico de los pacientes si lo hacemos bien versus si no hacemos una buena entrega de la droga. Este es el resultado final que pueden ver ustedes a nivel de la circunfleja. Como dice Simon, cuando uno ve estas lesiones, o me ha tocado verlo, decir esto, cuando uno ve estas lesiones, esta es la pura circunfleja, ¿no? Y uno dice, ahí yo no le pondría un stent, es que el resultado es bastante bueno. Y después, el resultado de la arteria del margen obtuso, véanlo, también quedan estas pequeñas estenosis residuales, son menores al 30%, a las cuales nos tenemos que adaptar, lo mismo que a disecciones tipo A, tipo B, que no limiten el flujo. Son disecciones que nos tenemos que adaptar en ese resultado temprano, pero no en el resultado tardío. Estas van a mejorar muchísimo. Y si vemos ya aquí, llama la atención lo que pasa después del stent a nivel distal, y cuando lo revisamos con A, vemos que tenía un mismatch. Sucede muchas veces con los probablemente letar esta angioplastía con un liberador de fármaco, y este es el resultado de la arteria descendente anterior a nivel distal del stent. Había un mismatch geográfico que no se veía en el primer resultado, y que sí lo pudimos ver en el seguimiento de los 5 días. Este es el segundo caso que les quiero presentar, un masculino de 82 años con múltiples comorbilidades, fibrilación auricular, con hipertensión, un ataque isquémico transitorio. Es un paciente con alto riesgo embólico y hemorrágico, claramente, que estará con anticoagulación a futuro, y que también lo que queremos es limitar la cantidad de metal que queremos poner ahí, y que tiene una alteración de la movilidad anterior y septal, así como una disminución de la fracción de expulsión. Se le hizo un CT scan donde se ve una placa claramente calcificada que abarca el tronco, que abarca la descendente anterior, muchas lesiones en esta tomografía de todas las arterias. Y aquí vemos la coronariografía, que si no hubiéramos visto la tomografía previa, pues no impresiona tantísimo la coronariografía. Sin embargo, sí se ve como hay muchísimo calcio en todo el trayecto, y estas lesiones que se ven por tomografía como algo muy significativo, aquí parecería por pura angiografía, y esto de repente las limitaciones de la angiografía no se verían tan enfermas, y una coronaria derecha pequeñita. Entonces, lo que nosotros hicimos fue tratar de pasar el IBUS para ver cómo estaba la lesión y todo el trayecto de la descendente anterior. Ya veíamos mucho calcio a nivel del IBUS, y pues como es de suponerse, cuando hay enfermedad difusa muy calcificada, el IBUS muchas veces, como ven aquí, no pasa, no avanza, y por los algoritmos de casi todos los lineamientos de cualquiera de las sociedades a nivel internacional, lo que se sugiere en este paso donde no pasa ni siquiera el IBUS o no pasan los balones, entonces lo ideal es hacer una terapia modificadora de placa con aterectomía rotacional, que fue lo que hicimos en este caso. Hicimos aterectomía rotacional de todo el segmento proximal, medio de la descendente anterior, algo de lo distal, y este es el resultado. Aquí, importante decir que la preparación de la placa es fundamental. Aquí estamos buscando estas fracturas. Todavía se ven zonas que claramente están estenóticas, pero aquí estamos buscando ya las fracturas y la modificación de placa que se ve ahí claramente, como le hicimos con la aterectomía rotacional, donde el calcio claramente ahora sí se ve una distribución de 360 grados, un calcio superficial en algunos casos, pero en otros casos un calcio muy profundo que puede abarcar toda la circunferencia del vaso. Y entonces la preparación de la placa, incluso para balones liberadores de fármaco, con aterectomía rotacional se lleva bien. Y bueno, ¿qué decidimos hacer? Predilatar muy bien. La preparación de la placa se debe hacer de preferencia con balones no complacientes, tardar quizás dos o más pasadas o dos o más infladas con esos balones no complacientes o balones de corte o aterectomía rotacional, como decía, de tal manera que podamos obtener muy buena ganancia luminal y una expansión completa del balón, que ya no haya un sesgo de este balón. Volvemos a pasar el IBUS para ver que está bien preparado, así fue, y después decidimos entonces hacer aquí una mayor preparación a través del IBUS. Vimos que necesitábamos mayor preparación y después la entrega de dos balones. Nuestra estrategia fue hacer en este caso una estrategia híbrida. Nosotros todavía no tenemos la experiencia que tiene Simon como para hacer todo con puro, incluso las partes proximales o tronco con puro balón liberador de fármaco. No tenemos todavía esa confianza de dejar los troncos sin stent, igual que la descendente anterior, la ostial en mi caso. Pero bueno, no queremos poner tanto metal y entonces la estrategia que definimos aquí fue una estrategia híbrida, poner dos balones liberadores de fármaco, que claramente aquí puede ser que incluso se hayan empalmado. Esa es la gran ventaja también de los balones liberadores de fármaco. Uno puede usar un poco más prolongado o un poquito más largo la longitud del balón, y bueno, esto nos da, no hay problema, ¿no? Y vean cómo queda la descendente anterior. Creo que en esta proyección se ve muchísimo mejor. Está el stent, pero después del stent vemos una placa muy preparada, pequeñas disecciones aquí que no alteran el flujo y que se ve prácticamente un vaso que podríamos decir que pudiera ser un vaso sano, todo el segmento medio y distal, y eso es una preparación y un resultado con balón liberador de fármaco que para nosotros es un resultado adecuado. Y ganamos diámetros. Teníamos el IBUS, vamos a ver el inicial y el final, y entonces aquí vemos el IBUS a nivel distal. Tenemos muy buenos diámetros del vaso y muy buenos diámetros también proximales por este stent. Quería compartir rápido estos dos casos, que me parece que son dos casos que pueden ilustrar claramente lo que es el día a día, no casos extremadamente complejos, pero casos que nos surgen en el día a día, y donde ya veía yo por ahí una pregunta de si usamos este tipo de balones liberadores de fármaco en placas complejas. Pues en el caso de calcificadas, yo creo que es un área donde los stents por años han fallado, y creo que es un área donde los balones liberadores de fármaco pueden ser una muy buena práctica, ¿no? Junto con pacientes de alto riesgo de sangrado o pacientes jóvenes que no les queremos poner stents, etcétera, etcétera.
Excelente, Alejandro. Simon, nosotros we already past the time, but is that okay? 5 more minutes just to answer the final questions? Okay,
of course,
great.
Yeah.
Nosotros valorizamos mucho las preguntas y la interacción, que fueron muchas acá. Aproveitando, Alejandro, sus dos casos, hay algunas preguntas acá preguntando sobre la terapia antiplaquetaria. ¿Cuánto tiempo? ¿Cuál el tiempo mínimo? ¿Cuál la recomendación? Rápidamente.
Rápidamente, en el primer caso, yo me guío por un síndrome coronario agudo, y entonces las terapias al menos 6 meses de doble integración plaquetaria, porque le pusimos un stent en el síndrome coronario agudo. En el segundo caso es un paciente estable, 3 meses sería suficiente, pero en el caso de puro balón liberador de fármaco, y no sé, el consenso podría ser que un mes es suficiente doble integración plaquetaria, y de ahí en adelante puede ser single antiplatelet therapy.
Simon, your practice.
Yes.
Depth post DCB alone. your
Okay,
practice?
so electively, generally, we would go exactly as Alejandro said, with 1 month of dual antiplatelet therapy. But in high bleeding risk patients, there's now data for just a single antiplatelet or a very, very short dual antiplatelet. If we come across patients, for example, that are on an anticoagulant that we don't want to interrupt, and they're very high bleeding risk as well, we would leave them on their anticoagulant and perhaps maybe just give them a week of a single antiplatelet in addition, as long as they left the lab with just a drug-coated balloon and not a stent, obviously.
Okay.
But there is a trial now. Sorry, there's a trial now.
Go ahead.
Thomas Risslin's doing his second trial in HBR patients, and he's looking at as short a dual antiplatelet therapy as you can in drug-eluting stents, which I think is now down to a month, against the shortest that you feel comfortable with, essentially, in the balloon arm, which can be just dual antiplatelet loading in the lab and then a single antiplatelet afterwards, for example. So a much more aggressive, shortened version. And the other thing to bear in mind is we were doing angioplasty only with aspirin before stents came along, and it seemed to work.
Okay. Sebastian Zeme tem perguntas acá para começar. Mário, qual percentual hoje dos seus pacientes que receben DCB?
Bueno, Sebastián, en mi práctica yo te diría que es casi 60%. La mayoría de los pacientes que yo hago lo hago como Alejandro con técnica híbrida o blend, pero yo creo que estamos como en un 20% de casos es que hacemos solo DCB. Esto viene antes del SELUTION DENovo, en una práctica que comenzamos hace 3 o 4 años en nuestro grupo.
Okay. Ricalde?
Yo ahora estoy haciendo prácticamente todo lo que es segmentos medios y distales, así como todas las lesiones ostiales con DCB. La verdad es que a mí en las lesiones ostiales es donde más me gusta, esos pacientes que tienen una lesión ostial de un ramo secundario y que el ramo principal no está enfermo, no me gusta nunca poner un stent. Entonces, esas hago hasta lo imposible por poner balón liberador de fármaco, incluso siendo circunfleja. Lo que sí es cierto es que hoy por hoy, todo segmento medio y distal, trato siempre de solamente poner DCB, nada de stents, es mi práctica cotidiana.
Em minha prática, em meu centro da antepazanese, teremos como que 2.500 procedimentos de intervenção por ano. No último levantamento, temos como que 200 casos com DCB também. Tenho que dizer que a maior parte ainda é a restenose intrastente. O número de casos que hacemos apenas o balão farmacológico ainda é pequeno, pero a estratégia combinada, que eu penso que é o que ficará na prática, stent onde necessário, mais proximal, depois podemos complementar com o balão farmacológico, evitar o excesso de metal. Isso temos crescido bastante em nossa experiência, pero acho que na América Latina como um todo ainda há muitas restrições de acesso devido ao custo e ao financiamento, mas a tendência, sem dúvida, é aumentar. Temos acá comentário de quanto tempo. Simon, acho que 30 segundos a 1 minuto normalmente é a recomendação, pero com Solution há algo diferente? O tempo de insuflação de balão? Há algo especial com Solution em comparação com os outros balões farmacológicos?
No, we in our center, we use 30 seconds for all the balloons that we've used, as long as that falls within the instructions for use from the company involved. And in the trial, we recommended a minimum of 30 seconds. There's a little bit of data that if you do a more prolonged inflation, you perhaps get a slightly better result long term. And that might just be something related to the additional angioplasty effect of a more prolonged inflation. But certainly in our hands, we've done so much lesion preparation up front with a lot of prolonged balloon inflations that I don't think it makes much difference. It does make a bit of a difference in stent restenosis, apparently. I'm not quite sure I understand why.
Okay.
About 30 seconds solution is what we do.
Okay. Last question, so so we can finish here. There are a lot of comments and questions, and even Alejandro has shown a couple of cases with imaging. People asking the role of imaging. Should we do or not? Pre, post, only pre, don't do post. Follow-up, should we do angiography? Should we have any other imaging method? Any criteria? How do we apply in ISR and de novo? Simon.
Wow, that's quite a big question.
Okay, imaging DCB overall, 1 minute.
Okay, so in ISR, I think there's much more of a demand for it because of understanding the reason for stent failure and then optimizing that as much as possible. So I'll leave that to one side. In the de novo work, I think there are people like our centre that have spent the last 15 years developing the way that we do de novo DCB. All of the trial data that's out there and all the consensus documents essentially talk about judging your lesion preparation and your result, and particularly the safety of your result on an angiogram. Now, I know there are lots of people, and it's very country dependent as to how much access you have to intravascular imaging. But people that are very keen on intravascular imaging would like it to be part of how you do DCB-only angioplasty. I don't think we yet fully understand how it will fit into that picture. It certainly reduces the event rates in drug-eluting stents, so it would make sense that perhaps it would reduce events in drug-coated balloon de novo work. I think it's very reasonable, if that's how you do your angioplasty, that you image everything, to use the imaging to tell you, for example, what size the vessel is that you're treating. I think I'm quite good on an angiogram, but I'd be rubbish on intravascular imaging, picking the right size all the time. But it also tells you how to do your lesion preparation. You can then image, as we just saw in some of those beautiful cases, after your lesion preparation to see if you've done enough work. I judge it again on an angiogram, but I know there are people that like to judge that on imaging. Now, with SELUTION in particular, we're quite keen that people don't image or instrument the vessel after the solution balloon, because we're worried about the idea of damaging the drug delivery system that's literally only just been put in. There is a little bit of work apparently coming out, which not yet available, that would suggest any DCB work that's been done with any of the products, you shouldn't do any instrumentation afterwards, because as soon as you start touching that vessel, you're going to be losing some drug. I think the most important thing currently, to my mind, is you shouldn't be solely judging the safety of your balloon angioplasty result on intravascular imaging, because everything that we've learned and all the trials telling you the very low event rates acutely are based on an angiogram. And everybody has to take an angiogram. We just need to learn how to look at it from the point of view of, is it a safe dissection or not? It's not difficult.
Okay.
How's that?
Simon, we're coming now to the end. This was just wonderful. Thank you so much. Now in Latin America, in Brazil, Buenos Aires, it's 9:15, close to 9:15. So for you, it's 11:15. So I mean, it's midnight. It's after midnight. So thank you so much for being with us this late. We learned so much from you, and we just have to thank you. Cannot thank you enough for that, on behalf of SOLACI. Acabei de ouvir acá, por uma voz misteriosa, que hoje é cumpleaños de Alejandro Ricalde. Então, parabéns, Alejandro. Muitas bênçãos para você.
Muchas gracias, así es.
Queremos agradecer a todos os participantes, em especial os apresentadores, os panelistas. A discussão foi fantástica. Todos que participaram com comentários, perguntas, em especial os atendentes que ficaram até esta hora conosco. E antes de encerrarmos, agradecer muito a Cordis por esse apoio para uma atividade científica e solicitar que Juan Ventura acá nos mostre na próxima semana. Teremos um novo webinar que será conduzido por Alejandro Ricalde, também um tema muito atual e excitante, que é o embolismo pulmonar os tratamentos. Teremos também evidências muito disruptivas vindo do TCT, e teremos participação internacional do investigador principal americano, também de projetos dos Estados Unidos, que a intenção é involucrar cada vez mais o cardiologista intervencionista na terapia desse problema, que sabemos a complexidade de manejo e também a fatalidade muito alta ainda que existe. Então, estão todos acá convidados para a próxima semana. Mais uma vez, muitas graças a todos. Simon, thank you so much. And I hope we have chance to
It's a huge pleasure.
discuss the sub-analysis will come. Thank you so much. Graças a todos.
Simon.
Muchas gracias.
Big pleasure.
Gracias.
Nice
Gracias.
to see you all.
Felicidades,
Gracias.
Alejandro.
Gracias.
Muchas gracias.
Parabéns.
Gracias.